I'm a senior lecturer and a research fellow at our institute, which we call NISAN for short, so I'll refer to that as NISAN. And what I'm presenting today is just a very brief overview of some of the findings of our research studies in stroke epidemiology and some of the current studies that are underway. So the first lot of studies that I'm going to talk about are the Archos studies. This Archos study stands for the Auckland Regional Community Stroke and Stroke Outcomes Studies. These are prospective population-based studies that have been conducted since 1981. So one of the reasons why we need to keep the surveillance of stroke and its burden in New Zealand is that, not just in New Zealand, but worldwide, stroke is still a leading cause of death and disability. And in New Zealand in particular, stroke affects Maori and Pacific populations in a very disparate way. So these Archos studies have been conducted for 4 rounds, starting from 1981, and we were involved in the most recent studies, the Archos 4 studies that were conducted in 2002. So, and these are ideal population-based studies, which means they're the gold standard way of measuring stroke burden. In Auckland, residents who are adults, and we collected the relevant clinical and demographic data around them. We also approached people to be consented into a more detailed follow-up study so that we could measure their outcomes in a more detailed way. So what we found in the Archos 4 studies was that there were over 2,000 cases of stroke registered in that year. Now, we collected most of this data from the hospitals, and Middlemore Hospital was one of the ones where we collected information from patients. So we had researchers who were either based at AUT but worked here at Middlemore Hospital and the other DHBs, or we had research nurses working here. Of the stroke cases that were registered, 77% were first ever in a lifetime strokes. And about 19% of people died within the first month after stroke, and 29% of people died within a year after stroke. In New Zealand, from the Archos 4 studies, we found that the first ever incidence stroke rate was 115 per 100,000 population, and this is standardized to the World Health Organization standards. In terms of international standings, New Zealand is not that great in terms of incidence rates. So we're worse off than Australia, where the incidence rates are around 95 to 100 per 100,000, and definitely a lot worse than other countries like France and the UK. In this Archos 4 study, we also looked at the incidence of TIA for the first time, whereas the previous Archos studies had not. And we ascertained about 785 cases of TIA in that recruitment year, with an incidence rate of about 40 per 100,000. And that's just to say that incidence rates are lower in other developed countries compared to New Zealand. So in summary, in 30 years, we found that there was a reduction in stroke incidence rates in New Zealand, as well as case fatality rates both for 28 days and 1 year. However, what we found, and particularly in the last 10 years, is that there is a trend towards an increased incidence in people under the age of 64. So stroke is traditionally thought of as a disease that affects older people, but increasingly, not just in New Zealand, but across the world, there has been an increase in incidence in younger strokes. In New Zealand, we also found in the last 30 years that there is an increase in the prevalence of the traditional risk factors for stroke, such as high systolic blood pressure, myocardial infarction, type 2 diabetes, atrial fibrillation. But happily, we saw that there was a decrease in the prevalence of smoking. And one of the reasons for that is, as we all know, the really big push with the government in population-wide strategies to reduce the prevalence of smoking in New Zealand. We saw ethnic disparities. Incidence rates in Maori and Pacific were higher, still significantly higher than in Europeans and Asians. These disparities have lessened, which is a good thing, but they have persisted. The average age of onset of stroke in Maori and Pacific is about 15 years younger than Europeans, which is a massive difference. So that was just a very, very quick and brief summary of stroke incidence and the burden of stroke in New Zealand. We also conducted a study which was funded, I forgot to mention that that stroke incidence study was funded by the Health Research Council. It was a program. We also conducted a small survey, a national survey, of 400 people that was ethnically stratified. So we had equal numbers of people who were Maori, Pacific, Asian, and European, 100 in each group. And we looked at, this was a telephone survey which was conducted by a telephone survey company on our behalf. And we asked a range of questions around stroke awareness. What did people know about stroke? Could they identify the symptoms of stroke? Could they identify what risk factors were important for stroke? And could they tell what one would do if someone experienced a stroke? From this survey, we found that overall, the awareness of stroke in the general population was very low. And what we also found was that the way people are asked questions gives you very different results. So if you give people a list of symptoms and say, do you think these are symptoms of stroke, they're likely to get a better response rate, a correct response. But if you ask people to identify symptoms of stroke or causes of stroke without giving them a list to say yes or no to, then the awareness of stroke is very, very low. And only about 30% of people identified one sign or symptom of stroke. Again, because we had an ethnically stratified population, we found that the awareness of stroke in terms of symptoms and identifying its causes was the lowest in the Pacific group. So, given this information, given that the Archos studies show that stroke rates are quite high in New Zealand compared to other developed countries, and that there are still ethnic disparities, and that we know that stroke awareness is quite low in New Zealand, particularly in Pacific people, we have continued to try to find ways to reduce these disparities and to reduce the incidence of stroke. So a lot of our research that we're conducting at the moment is focused on primary prevention. At the moment at AET, we're running 2 primary prevention trials. The first one is known as the PREVENTS trial. This is a randomized clinical trial which is funded by the National Science Challenge Aging Well, which is looking at an intervention, a psychological intervention known as health and wellness coaching, which is aimed to reduce cardiovascular risk in people who are already identified as having moderate to high risk of stroke. The second trial is a similar trial, but this is a pilot trial looking at the feasibility of using a mobile app, which is a stroke, an app that allows you to measure risk of stroke, but also gives you a lot of information about stroke in terms of education for behavior change and for primary prevention of stroke and cardiovascular disease. So the health and wellness coaching study is underway. Recruitment will finish in 2019. Follow-up will finish in 2019. At the moment, we have about 150 people in this trial. So they have 15 coaching sessions over 9 months, and the primary outcome is a clinically significant relative risk reduction in CVD. And the MARS trial is a similar study. We've actually completed this trial now, and hopefully the analysis findings will be out in the next month or so. And finally, before I finish, I'd like to just acknowledge all the study participants from the Archos and both those trials we're running now. Thank you.